G'day, Kato. Nomai Hanmai. Welcome to another In Conversation here at the OT board. I'm joined today by Harsh Vardhan, who is we're going to be discussing some of Harsh's career and where he is now, where he wants to get to, and what his thoughts are about occupational therapy for the future. So, Harsh, welcome. Good for you to take some time out to have a discussion with us. So you started your career as an OT in India. I wonder if you could just give everybody a sort of a view of what practice was like for occupational therapy in India when you were there.
Thanks, Andrew. First of all, thank you for having me here. In terms of practice in India, I think I need to give you a bit of background of what was the experience as a student of occupational therapy in India. And as you would know, India is occupational therapy has been in the country since 1954. So India is one of the founding members of WFOT, that is World Federation of OT. But unfortunately, even after so many years, occupational therapy is still struggling to make its existence. So this is one of the challenges. And the occupational therapy undergraduate programs, they are very much based on medical model. And that gets reflected when you get into practice. So, same happened with me. When I passed out, more or less, I was more into medical model of practice, and which has got its own merits and demerits as well. Other thing to consider is the gap between have and have-nots. So in my practice, I worked with clients who literally they struggle to have meals for the day, and they used to come in outpatient, stand in the line, waiting to get to see a therapist for 1 to 2 hours, and if they're fortunate enough to get an appointment on the day, I used to get to see them. On the other hand, this other group who are well off and kind of you may be able to fit them in a millionaire box, and who afforded everything and as much as they could afford employing an occupational therapist for themselves. So there's a big gap, and most of the health and disability funded services are privately afforded by people. And there is some government, funded services, but most of them is the private practice is quite well established in the country.
Right. So where did you work then once you graduated? In the public system or in a sort of private system?
So once I graduated, I started to work with one NGO, and it was so my clients, they were not required to pay for the services. So we used to work with low socioeconomic areas, slums. I still remember going on visits in slums, and it was my second or third month in the new job, and I was asked to follow up with some of the clients. And I thought, it would be as simple as picking up the telephone and ringing them and asking how they're doing. But no, this follow-up was in the field. So I had to get into the slum and did not have any address. So literally we used to go door to door and ask for people. So do you know this person, where he lives? And do you know this child? So that was an experience in itself. So one full day, and I was able to follow like 4 or 5 clients. So yeah.
So what sort of things were you seeing these clients about? What was the practice area?
So we were basically, the focus was, of course, occupation. And In my first job, it was mostly related to working with persons with neurological disorders like cerebral palsy, and they had postural needs, seating and positioning needs. So it was about providing them an appropriate seating equipment and and being creative. I'm saying creative because we did not have luxury of what we get in New Zealand, like the government funds for these flash equipment and housing modifications. We had to be creative and to use whatever resources were available in the community at the time to provide our services. So occupation was the main focus of the intervention.
And just going back to when you said that the curriculum or practice was very sort of medical model, how was that translated into practice? Were you acting under the direction of medical practitioners, or was it just that the curriculum was based around a very medical sort of view of the world?
Yeah, I mean, though the curriculum was very much in the medical model, it did affect our curriculum and the way we studied various subjects. But fortunately, when we were in practice, we practiced independently. So I was not working under any medical practitioner at the time. So I was able to plan my own intervention based on the assessment which I did.
Yeah. And so when you think of occupational therapy from a sort of a New Zealand Western perspective, it can be broken down into discrete areas, can't it? So physical, mental health, pediatrics, burns, etc. What was it like in India? Did you have those discrete areas of practice?
Yes, we did. So pediatrics is definitely a well-established branch of occupational therapy in India, and perhaps the most important one. I'm saying important because that is an area most of the practitioners get into because there is more awareness of pediatric occupational therapy, rehabilitation, mental health, even plastic surgery, orthopedic rehabilitation. So yes, these specialized branches are there, and there are various postgraduate training programs which offer courses around it.
Yeah. And the hierarchy that exists in many professions around, coming in as a new graduate, then moving up the scale to being a senior or a consultant in a particular area. Was that something that was that similar in India?
It is, and unfortunately, it is that hierarchy, which, like for example, in my first job, I was given a designation of associate occupational therapy and occupational therapist, and I was always struggled to see it as like, either you are an occupational therapist or you're not an occupational therapist. What does associate mean? So yes, hierarchy is something which is there pretty much now as well.
Right. And so I'm talking about India like it's a small place, but in actual fact, it's a huge place. And so what you've said about your experience and the way that occupational therapy is practiced in India, would that be true for all the states in India?
Generally, and like, of course, you cannot generalize it, but more or less that is, the context in most of the parts of India.
Right. And what's the pay and conditions like for an Indian occupational therapist?
Paying condition is when I compare it with say New Zealand, you can say in Indian context, you can say it's similar to what they get paid in New Zealand. Of course, when you will convert it into New Zealand dollars or or vice versa, you will see there's a big gap. But when you talk about the context, that it's similar condition to New Zealand, I would say.
And obviously they have a Ministry of Health, and I think the Minister for Health in India is actually called Harsh Vardhan. Is that right?
Yes, yeah.
You don't get any of his emails, do you?
No, I don't.
I should imagine he's very busy at the moment with COVID. But there is that structure in India where there is a minister of health for the country rather than individual states.
Yeah, so in Indian governance, there is one Minister of Health who looks after the health services of the country. Of course, he's the head of the health ministry. But then there are different states, and different states have their own health ministers as well.
Right.
So this big health minister sits at the top, and
Yeah.
then there are ministers of the state for health. And you talked about Harsh Vardhan, who is the minister, and he has a connection with occupational therapy in India.
Oh,
He was the person who, I think he was the first person who helped to form a regulatory body for occupational therapy in the state of New Delhi.
right.
And so he was the minister at the time,
Okay.
and he was responsible for bringing that legislation.
And so
So
regulation in India then, is it state dependent rather than countrywide? Does it vary?
yes, yeah. Unfortunately, there is no unified regulation countrywide. So uh, mostly it is state dependent. Some states have a regulatory body. Other states, it is basically self-regulation through the membership organization, that is the
Right.
All India Occupational Therapy Association.
Mm. Okay, good. And so the chapter for India closed, and you opened a new chapter, moving here to New Zealand in 2009. You moved here.
Yes.
So what prompted that change, Harsh?
For me, I was living in New Delhi, so it was quite a busy city, and I was doing quite well professionally, and at the time. But I also wanted to explore other parts of the world. I wanted to see how it is like practicing in other places. I'm a kind of person who likes challenges, who wants to explore the unknown.
Mm-hmm.
And I think it was that desire to explore the unknown, and coupled with like I get fascinated to nature, to countryside. And when you look at New Zealand, when you go through websites and look about the information related to New Zealand, you see this lush green farmlands and sheep and cows, and they always fascinate me. So
Yes.
that was another reason. So these were the main combination of things which made me to decide.
Yeah. And how easy was it? Hope I'm not shooting myself in the foot here by saying this, but how easy was it to get registered and move to New Zealand from India, from New Delhi?
It was, of course, I was not too sure at the time what was expected, sorry, in the registration process. So I had no one who could guide me at the time, who could say, look, this is how it works. For example, when I was writing competencies, I did not have sample competencies or some guidance, how you have to write. Do you need to write 1.1 example this,
Yeah, yeah,
1.2 example this? So I wrote in paragraphs, which later on I realized I should have written, point-wise instead of writing paragraphs.
yeah.
So to tell you frankly, it was not a very difficult process, and the board was very helpful. The people at the board at the time were helpful. And I guess you were the chief executive at the time.
Yes, yeah,
Back then. So yes, I remember you since then. And yeah, so it was not difficult. It was a friendly process, I would say.
Oh, great. No, that's good. And so you arrived in New Zealand.
Mhm.
What were your first impressions of occupational therapy in New Zealand?
Well, yeah, that is taking me 10 years back, Andrew. And as far as I can recollect, when I walked in, as occupational therapy is more about occupation
Mm.
and what we do in our day-to-day lives. And of course, the context changes. So coming from a different culture, a different country, coming to a new place, for me, one of the challenges was to observe and analyze what is the occupation of people in New Zealand. I mean, basic occupations remain the same. We all eat, we
Yeah.
all do things. But then how do they do it? I still remember in one of the groups, so this was my orientation in the department, and they asked me, can you go and help this occupational therapist for a group session? So I went, yes, I'll go. So I went there, and the therapist was teaching children, and the activity was cutting Play-Doh with knife and fork. And I was thinking, goodness sake, I'm not confident in doing knife and fork, right? What am I going to teach, right? And so this is one of the experiences. And then, of course, you go to the basics of occupational therapy, and then you go into, okay, so this is an occupation. You analyze it, you break it into components, and then so yeah, so the core of occupational therapy and OT process was similar, but of course the context was different.
Where was this, Harsh?
So this was in Hutt Valley DHP, the
Oh.
Child Development Service there.
Yeah. Okay. And then, continuing the child development thing, I understand that your area of practice in pediatric was develop a sort of diagnostic framework for developmental coordination disorder. Can you tell us a little bit about that?
Yes, of course, and it sounds like a flash thing, developing a diagnostic framework. Well, I should give you a bit of background on why I did that. I remember when I was appearing in an interview for Child Development Service, and one of the things in the job description is said that I'll have to do assessment and intervention for children affected by developmental coordination disorder. Now, at the time, to be honest, I was not much aware of that. So I did lots of reading. I wanted to, mug up certain things and just vomit it out during the interview if I get asked. So anyways, that happened, and I got into the job, but this was still going on in my head, and it was like 2 years, and I rarely came across a child with a diagnosis of developmental coordination disorder. And I was thinking, why is that happening? Why we do not see these children? So I started digging more and more, and what came out was the needs of these children were there, but they were falling into cracks. And there was some research, like one of the researchers they did in Canada, US, and UK, that only 25 or 23% of pediatricians have diagnosed DCD in their life. And only 9% or so general practitioners have come across dyspraxia or developmental coordination disorder. And one of the reasons which I discovered in my research was occupational therapists have a significant role in that diagnostic process. So what was happening in our DHP level is that these children were getting referred to our service with concerns like this child cannot tie shoelaces, someone cannot ride a bike. And the occupational therapist will pick up those referrals. But there was a question in the referral almost always, and which said, the pediatricians would send a referral and say that, well, can you comment on diagnosis, whether the child has dyspraxia or coordination disorder or not? And that is where occupational therapists were hesitant to call that. And when I researched, I found people were not comfortable giving a label to children. And there was some philosophical reason why we don't believe in diagnosis. At the same time, a big group of people, they thought that this is out of our scope. We should not be doing that. But anyways, we are the people who know the most about that condition, which I think we occupational therapists can contribute really actively in that process. And with that idea, I started working on a diagnostic framework. And that was the time we got in touch with the OT board, and you guys were very supportive of that. I remember getting an email from you through the president of the association at the time, which said, if you are competent of making diagnosis or helping in a diagnosis, there is no reason why you should not be.
Yeah.
And that was a turning stone. And from there, I got buy-in from team members and all other people, and we started to do that. 10 years down the line, still my ex-colleagues, they are actively diagnosing DCD and dyspraxia, and we have identified so many children with these challenges, and they have been able to get the right support at the right time.
That's good. That's good to hear. And so now, more recently, you've taken up a new role in the Ministry of Health. Can you tell us a little bit about that role that you've got, and perhaps how you're using your skills and experience as an occupational therapist in that role?
So first I'll answer your first part, and that is about the role and what it is. So I'm working as a program manager for child and community health services in the ministry, and it sits under the Population Health and Prevention Directorate. And the program I have been managing is the National Fetal Alcohol Action Plan. So it is a cross-agency action plan, which is basically has a vision to prevent FASD, fetal alcohol syndrome, and also to provide support to people affected by FASD. And so as it is cross-agency, the different ministries and government departments are involved, and we work towards the vision. One of the parts of the program is some initiatives which are funded by Proceeds of Crime Fund, and the initiatives are around establishing assessment and support pilots in child development services, developing guidelines for diagnosis and support for people affected by FASD, doing some research. So there's a range of initiatives, and a couple of initiatives are around using sensory-based self-regulation strategy, again, an occupational therapy-related intervention program, and utilizing them in youth justice residences, corrections, and education environment. So as program manager, my job is to oversee and manage that program management framework.
So you mentioned that it's interagency. From your vantage point, that to me suggests a degree of frustration around the various agencies not being on the same page and following, a vision, as we call it, for the development of a service and the support to those people suffering from that fetal alcohol syndrome. Is there that interconnectedness, or is there a disconnect with the interagency approach?
Yes, and I do accept when you're doing any interagency work, it does have frustration, but at the same time, the advantage is that you have got so many people around you from different agencies who bring so many different lenses to look into things. And when you put that energy together, you can get an outcome. For me, and thinking of from a pediatric occupational therapy perspective, sometimes I feel like I walk in a meeting where I have to talk about a child and the child's needs. But then there are parents, there are grandparents, and they all have their own views, and they all have different ways they can support the child. But sometimes you'll have to work with them and bringing them to the center and thinking about, so yes, we all have these agendas, we have these strategies and priorities. How can we align them to help this child who really needs the support? And program management in this interagency situation is not very different from that. It's on a different scale, but the fundamentals are usually similar.
And so if you're the project, did you say project manager, or for this project? Did you say is that what your title was?
So my title is as program manager.
Program manager.
Yeah.
Great.
Yeah.
So what will success look like for this project?
For me, this program, the success would look like we are doing certain initiatives, right? And when we are doing initiatives, these are pilots. You cannot do pilots in too many areas at the same time. We have got, to try it in certain areas. So for me, success is we are working on the fringes. We are working on the periphery. But in long run, when we get some result, in these projects, ideally, I would like to that gradually become the core and become part of business as usual to support these children and families affected by FASD. So to me, that is what success looks like. Somehow to scale these projects and bring it to the core.
Okay. So thank you. That's really interesting to hear you sort of moving that forward. Changing tack now and looking further into the future. What do you hope for occupational therapy in the future? And I'm not just talking about what actions you're taking within the Ministry of Health, but when you step back and look at New Zealand and occupational therapy and its place there, what do you see? What do you hope?
That's a good question. I'll attempt to answer your question, Andrew. I don't know whether it will be right or wrong. Well, what I see is that what has happened with time. When I look at healthcare, it has evolved. Healthcare in general has evolved. There was a time when whatever service you provide free of cost, that was the best healthcare, somewhere in 1930s and 40s. And gradually we went into prevention space, and then we went into evidence-based practice in 90s. And I know you are a registered nurse, Andrew, and you would relate to it. Nursing was the first profession who talked about evidence-based practice. And then evidence-based became the buzzword, right? And then we came in 2001, we started to talk about being efficient. So how to do more with less you have. Where we are moving towards is more about, yes, the evidence is there, and there are so many evidence to do things, but what can we provide which gets valued by the consumer? Or we are moving towards personalized healthcare. We are moving towards precision medicine. So this morning I looked into one of the articles in LinkedIn. The UK have published their world's first strategy on precision medicine. So precision medicine, genomics. Yeah. So, and it talks about how you can do things like gene editing and cure some of the diseases or conditions. So what will be the role of occupational therapy in that? So we have to think on those lines in next coming 20, 30 years. We also have to think about systems as a whole, how we can bring change and where occupational therapy fits in that, and basically joining the dots. By our core is very much based into networking. As occupational therapists, we believe in network, we believe in connection power, and that is how we influence and drive change. And this is the era of that. So we are moving, healthcare is moving towards, they call it a new prescription of power, where you will influence by connecting and networking. And that is what we need to do in future. So, and things like artificial intelligence, transformation, health transformation, how we can be part of that. So in this era, it is not just about making good things better. We have to think about how we are developing new things. And, how will occupational therapy look like in next 20 years? Do we need to make what we are doing now better, or we want to get into newer space, the space of well-being, the space of what we can do in New Zealand context with tangata whenua healthcare, whanaora approach, what is our role there? So these are some of the challenges for us in future, and I think that is a way forward for us.
Thank you, Harsh. That's you strike me as somebody who is sort of really switched on and conscious of the contribution that occupational therapy can make to health and disability services. And somebody you seem to have a lot of energy around that. I'm just interested in how do you switch off at the end of the day? If you do, what do you do
At
to
the end of
relax?
the day,
Yes, to
yeah.
relax.
So I have got my family at home and two young kids. One is 7 year old and the other one is 3 year old. Sorry, 10 months old. Not three yet. Not three yet. Long way to go. And my wife. So I think I like that, family time, and just spending some time with family, the kids, and they make me, you know, really happy. And yeah, so I always look forward to going home and spending some time with them. So that is quite relaxing for me.
Right. Okay, Hash. Listen, thank you for the time. Thank you for your honesty and describing, how it's been for you from moving from New Delhi into a new country, um, yeah, to New Zealand, and really still pushing ahead and forging ahead with your ideas, and obviously having an opportunity to do that at a higher level now. You've moved into a position in the Ministry of Health. So thank you very much for your time, and good luck with all the plans for the future, and keep the flag of occupational therapy flying wherever you are.
Thank you very much, Andrew, and thank you for having me here. I appreciate it.
Great. Ka kite ano. Thank you.
Kakite.